Hello, everyone, and welcome to today's webinar, Strategies to Optimize Drug Testing. What's in your panel and what are you missing? I am Michelle Ashton of LabRoots, and I'll be your moderator for today's event. Today's educational web seminar is presented by LabRoots and brought to you by Thermo Fisher Scientific. To learn more, visit thermofisher.com. Let's get started. Before we begin, I would like to remind everyone that this event is interactive. We encourage you to participate by submitting as many questions as you want at any time you want during the presentation. To do so, simply type them into the Ask a Question box and click Send. We'll answer as many questions as we have time for at the end of the presentation. If you have trouble seeing or hearing the presentation, click on the Support tab found at the top right of the presentation window, or report your problem by clicking on the Ask a Question box located on the far left of your screen. This presentation is educational and thus offers continuing education credits. Please click on the Continuing Education Credits tab located at the top right of the presentation window and follow the process to obtain your credits. I now present today's speaker, Dr. Jaime Noguez, the Medical Director of Chemistry and Toxicology at University Hospitals Cleveland Medical Center, Assistant Professor of Pathology at Case Western Reserve University. For a complete biography on our speaker, please visit the Biography tab at the top of your screen. Jaime, you may now begin your presentation.
Thank you, Michelle, for the introduction, and I'd like to thank all of you for attending this webinar. Some quick housekeeping. The thoughts and views in this presentation are my own and do not reflect those of Thermo Fisher Scientific, but I would like to thank them for sponsoring this webinar. All right, so the objectives of my talk today are several-fold. I'll start by introducing the concept of toxicology testing, and then describe some of the various technologies that are available and commonly used in drug testing. I'll provide some examples of several clinical scenarios where drug testing is commonly requested, and then describe some approaches that you can use to design your drug test panels to ensure that they meet the various clinical needs. So let's get started. So there are many important decisions that need to be made to ensure that your drug testing program meets your stated goals and is successful. And so an important first step then is to understand how the urine testing process works, what the testing can and cannot tell you. So we'll get started by reviewing some basic concepts in drug testing. So a toxicology screen is a test that checks for drugs or other chemicals in your blood, urine, or saliva. When I say blood, I'm referring to serum or plasma, which is what's most commonly tested. A tox screen can check for one particular drug or for many different drugs all at once. And so this can include prescription medications, over-the-counter drugs like aspirin, or things like vitamins, supplement, alcohol, and even illicit drugs like cocaine. There are four general categories of toxicology testing. There is forensic toxicology testing, which is conducted by a laboratory for medical legal purposes. There's workplace drug testing, which is often done pre-employment as part of the interview process, or after someone's already been hired on as random drug testing to enforce a drug-free workplace. There's athletic drug testing, which typically looks for banned substances or performance-enhancing agents, and this is typically done in competitive level athletes. And then there's clinical drug testing, which is conducted to assist in patient diagnosis and treatment. So my talk today is going to focus on this last category, clinical drug testing. So I'd like to give you some examples of common scenarios, clinical scenarios where drug testing is ordered. It's often ordered in the emergency department when a patient presents to the ED with a suspected overdose or poisoning, if they've been involved in an accident where there's injuries and there's any suspicion of substance abuse, if they present with life-threatening symptoms, they're unconscious, or if they're exhibiting strange behavior, a physician might think that they should order a drug test. Another scenario is controlled substance monitoring. So in these situations, the physician is looking for the presence of the medication that they've prescribed in order to gauge compliance. They're also looking to ensure the absence of non-prescribed medications or any illicit substances that the patient may be taking. Another example is therapeutic drug monitoring. So in these scenarios, the physician is checking drug concentrations to ensure that they are at the appropriate levels in order to provide optimal therapeutic effect for their patient. They're often ordered for evaluating perinatal maternal substance abuse, right? So this allows us to facilitate placement of these expectant mothers into treatment programs. Yet another example is an addiction recovery program to monitor treatment plans and to identify relapse. And so these are just a few examples of how drug testing is ordered in the clinical setting. But in general, it can be ordered in any situation where you want to detect drug use or abuse where you think it can have a negative impact on patient care. So we can do these testings in a number of different matrices. So serum and plasma, hair, urine, saliva, sweat, and breath. But the most commonly used matrix in clinical testing is urine, and there's several reasons for that. So urine collection is non-invasive, meaning that you don't require a phlebotomist to do it. The patient can collect it themselves. Typically, there's more than enough volume to do the testing that you need to. There are long detection windows relative to some of the other matrices. So if you look at the table to the far right, you'll see that there's a chart with the relative window of drug detection for various matrices, with urine being right in the middle of that table. And so we have a range of minutes to sometimes even weeks for detecting some of these drugs. Most drugs and their metabolites tend to be excreted in urine in higher concentrations than what they're found in blood, which makes them easier to measure. And the analysis is relatively simple compared to some of the other matrices because it's pretty clean. So there's not a lot of proteins or things in it that would make it technically challenging to measure. That being said, there are still some challenges with measuring drugs in urine. So urine can be easily substituted, diluted, or adulterated unless you're performing an observed collection, which often is not done in the clinical setting. The donor may be unable to provide a specimen at the time that you need them to, so they could have a shy bladder. There's a lack of correlation between the drug level with intoxication, and drug levels can vary widely. So you can give two different patients the same drug, the same dose, and they can have different levels of the drug and the metabolite in their urine. So drugs vary considerably in how quickly they pass through our body and that they can be detected in our urine. And so this variation depends on a number of things, including the nature of the drug itself. So its kinetics of distribution. So what's its half-life? What's its solubility? Does it prefer to stay in our bloodstream, or does it accumulate in our fatty tissues? It depends on an individual's metabolisms, which is dependent on their liver function or their kidney function, so how quickly they can metabolize and excrete it from their body. It depends on the hydration status of the patient prior to sample collection, the frequency of drug use, so whether they are using it just one time versus chronic use, and the time and size of last dose. So I'd like to direct your attention to the table on the right. So this shows the approximate drug detection times in urine of several drugs and drug classes. And so I'm not intending to go through each line, but I just want to highlight that there are some drugs or some substances that we can detect for a very short window, like alcohol. Others that we can detect on the order of days, like oxycodone, so roughly 2 to 4 days. But then there are substances like long-acting benzodiazepines or chronic marijuana use where we can detect on the order of weeks. So there's quite a bit of variation. There are two main types of urine drug tests. So there's a drug screen, which is an initial test that we can use to identify potentially positive and negative specimens. And these results are typically reported out as preliminary, presumptive, or unconfirmed positive and negative results. Then there's a drug confirmation, which is a more specific test that provides definitive identification of the drugs in the sample as well as their metabolites. And so these results are often reported out as definitive or confirmed positive or negative results. Immunoassays are the methodologies that are typically used for this type of screening because they're sensitive, quick, and inexpensive, and they really only require a small amount of sample. They rely on the interactions between antigens and antibodies to detect the presence of either an entire drug class, so opiates as an example of an entire class, or a particular drug like cocaine. They are usually qualitative, and they can indicate the presence or absence of a drug or its metabolite at a given cutoff. And so these cutoff levels can vary depending on which drug you're testing, and they're established by the manufacturer to help minimize the number of false positives. So if you look at the table on the bottom right, this just shows an example of a number of different drug tests, and in the parentheses, the cutoffs that have been assigned for them. So for these screens, they're fairly sensitive, but they're not specific. So we are sacrificing some of the specificity in order to achieve broad reactivity and detect drugs in an entire class. So these qualitative screens, or these immunoassays, their cutoffs are calibrated or set using a representative drug. And so this is a compound that's intended to represent the entirely structurally similar class. And so the chart here shows just a representation of some of the representative drugs and cutoffs that might be used. I'm using it only for the sake of making a point and explaining a concept. So I will use the opiate assay as the example with morphine as the representative drug, setting a cutoff at 300 nanograms per mil. All right, so the cutoff is set then by running a known concentration of morphine, which would be 300 nanograms per mil here, which will be our standard in our assay, and it will generate a signal. And we see that 300 nanograms per morphine generates an absorbance of 0.80. So when we go to run our patient sample, our unknown, any samples that generate a signal of 0.8 or above would be considered positive, and anything that generates a signal that's less than that, or maybe no signal at all, will be considered negative. That's easy enough, pretty straightforward. But one of the challenges or limitations of immunoassays is that they demonstrate variable detection of compounds within a drug class. So what do I mean by that? So I'll further expand on this on the next slide, continuing on with the opiate screen as an example. So typical opiate immunoassays, they're designed to detect the natural opiates and their metabolites. So in the table below, they're shown in green here, the natural opiates are those that are derived from the opium plant directly. So these are your morphine, codeine, etc. And their structures are shown at the bottom left of the screen with the names in green. Then there's the semi-synthetic opioids. So these are not exactly derived from the plant, but they have the same chemical backbone that's been modified to modulate their biological activity. So these are your hydrocodones, oxycodone, hydromorphone, etc., listed in gold in this table, and their chemical structures are shown in the middle of the slide. And so just by looking at these, you can see that their structures are very, very similar to the natural opiates, which we would expect. Then there's a totally different class. There's the synthetic opioids. So these are manufactured completely. They are fully fabricated. There's nothing natural about them. These are your methadones, your fentanyl, and your tramadols. And if you look at their chemical structure shown on the bottom right of the screen, you can see that they are structurally very different, right, than either the natural opiates or the semi-synthetic opioids. So as humans, we tend to categorize these drugs as opioids, right, because of the biological effect they have on our bodies, but the actual immunoassay or the test actually categorize them quite differently, right? So the ability for them to detect the drugs within a class will vary as the chemical structures change. But to further drive this point home then, in blue, I have the concentrations that are needed to produce a positive opiate screen using a cutoff of 300 nanograms per mil as I described. So obviously for this assay, we would only need 300 nanograms per mil of morphine to trigger a positive result because that's what we use to calibrate it. But notice that we need less codeine to trigger the same signal or to generate the same signal. We would need about 5 times as much oxycodone to generate the same signal amplitude, and we would need about 50 times or more of fentanyl to create the same signal. So the ability to detect drugs within a class varies as the chemical structures change. Thankfully, our assay manufacturers include this cross-reactivity information in their package inserts. So they have information about the compound that they're testing, and then the concentration that's required to trigger a positive reaction in their particular method. So this is just an example of one here, and you'll see that they also include the concentrations required of many of the metabolites. So morphine metabolizes to hydromorphone, and you can see from this chart that you need roughly 500 nanograms per mil of hydromorphone to trigger this result as this test to be positive. So almost twice as much of the morphine metabolite as morphine itself. So this is a very helpful tool. So some food for thought then. A negative urine drug screen does not always indicate that a substance isn't present, right? It can also indicate that there's just poor cross-reactivity of that particular substance in that screen. that the substance is present, it's truly there, but it's just below the established cutoff concentration, that the specimen was collected at a less than optimal time relative to drug administration, so you're not able to detect as much of it, or that the specimen was somehow diluted or adulterated in a way that prevents it from being measured. And I'd like to continue on with this concept of cross-reactivity. So cross-reactivity occurs when a test cannot distinguish between the substance that's being tested for and the substances that are chemically similar. And so this is a good thing in some ways, right, because this gives us the broad cross-reactivity we need to detect an entire class of drugs. But there's a flip side to that. It's a double-edged sword in that sometimes you might also pick up on things that you're not really looking for. And so I feel like this is well illustrated in the cartoon below. Well, so I'll walk through this. So we have an assay that has anti-A antibody that's designed to detect antigen A, which is this upside-down looking T structure. Anti-A antibody is not very specific, so it's also able to detect antigen B, which has a shared epitope with antigen A. So the light blue portion of antigen B is what's shared with antigen A, and then the yellow portion is what's unique to antigen B. Now, because anti-antibody A is not very specific, it can also cross-react with antigen C, which doesn't share any epitopes with antigens A or B, but it just looks structurally similar. It's a similar looking epitope. So it kind of looks like an upside-down T. So how does this relate to drug testing then? So you have an assay that's designed to detect amphetamine. It's also able to detect methamphetamine because they share an epitope. They're very structurally similar. But it'll also detect bupropion, right? Because if you look at this from a 3D perspective and chemically, they look very, very close. So your assay may not be able to tell the difference between the two of them. So practitioners and laboratorians, we should be familiar with this potential for cross-reactivity and ensure that our physicians are asking their patients about what other prescriptions they're on, what other over-the-counter medications they might be taking that may potentially cause a false positive in their test, in their drug screening test. This is also where confirmation testing comes into play and comes in very handy. So confirmatory drug testing, it can be used to confirm the results of a screening test, whether it's positive or negative. So it can be used to confirm that the screening test in fact detected the target compound and not something that's just structurally similar. But you could also use it to confirm that there isn't any drug present at a concentration that's below the cutoff threshold. Typically, this type of testing is done using a higher level method, using technologies that can separate and quantitate compounds based on their chemical properties as well as their mass. And so most commonly, gas chromatography mass spectrometry and liquid chromatography mass spectrometry are used. And so in the upcoming slides, I'll touch more and describe these technologies. But confirmation testing can also identify specific drugs within a class. So instead of just being able to say that someone is positive for opiates, you can specifically say that they are positive for the drug oxycodone as well as its metabolites noroxycodone and oxymorphone. Confirmatory testing also provides quantitative concentration. So you not only know exactly which compound is in there, but how much of it is present. The limit of detection for these tests tend to be lower than screening tests because of the nature of the method, and they provide higher sensitivity and specificity than screens. So just a quick review then about these technologies. Chromatography is a collective term that we use for a variety of lab techniques that can separate the components of a mixture into its individual parts so that we can analyze, identify, purify, and quantify them. So most biological matrices, so that we're testing in the clinical setting, they're very complex, and that can make complete characterization quite challenging. So this is where we can use chromatography to help us separate the components of a mixture. So the components of the sample are separated based on the distribution between two phases. There's a stationary phase, which is, as it sounds, stationary, stays still. And then there's a mobile phase, which is pushed through the stationary phase. Now, the composition of these two phases can vary depending on the intended use. And by that, I mean it depends on what compounds you're trying to separate. So the user gets to choose the properties of each of these phases. Substances that have the weakest interaction with the stationary phase, they will pass through faster than those that have strong interactions. So you end up having several different fractions with different molecules eluting at the time that reflects their level of interaction with both phases. Mass spectrometry is an analytical technique that we use for the quantitative analysis of compounds within a sample based on their mass. So in general, all mass spectrometers, they have these basic components. They have an ion source, a mass analyzer, and an ion detector. Now, the nature of these components can vary. You can mix and match. There's different types and create different types of instruments. But in general, mass specs have these basic components. So the samples are loaded into the inlet. They are then vaporized, meaning they're turned into a gas, and then they are ionized at the ion source. They then move into the mass analyzer, which separates the ions based on this mass to charge ratio. And then they go into an ion detector where these charged particles can be detected, and we can get a chromatogram that tells us what particles are detected and the relative abundance of each. And so using that data, we can either identify compounds by correlating the masses that we're seeing to the known masses of the compounds that we're looking for, or through a characteristic fragmentation pattern that matches a compound that we know fragments the same way. So when you pair chromatography with mass spectrometry, you're able to improve the specificity of your drug testing. So GC and LC-MS, they separate analytes in a sample based on their retention time and their mass. So you can be very confident that you're detecting the molecule that you're interested in if it, one, elutes at a specific time from the column, and two, if it has a specific mass and charge. So some of the advantages of using mass spec in the clinical setting are that you have high sensitivity and specificity. The linear range can be quite wide, so you don't have to do as many dilutions. It has high accuracy and precision. You can remove many of the nonspecific antibody interferences that you would see from immunoassays. Depending on how you develop your method, they can have short run times and require actually quite low sample volumes. Mass spec can be a cost-effective solution for drug testing, but I would say that the initial outlay of capital is quite expensive, but the actual reagent thereafter is quite inexpensive. And then for the last 2 points on here, I wanted to specifically highlight because I think that they're particularly pertinent for drug testing. So mass spectrometry gives you the opportunity to multiplex your testing. So that means that you can test for several different compounds at the same time in a single injection. So for example, one of the methods that we run at our institution, we can measure 66 different compounds in just 100 microliters of urine. So instead of doing testing sequentially, we can test for all of these at once in the same injection. Another benefit of mass spec when it comes to drug testing is that you can detect and differentiate the parent compounds from the metabolites. So for those of you who aren't particularly familiar with the opiate and benzodiazepine metabolism, so these are just some of the more commonly ordered medications, at least in our system, I just wanted to highlight that you will sometimes see a mixture of parent compounds and the metabolites. Sometimes you'll only see the metabolites. So it's good to build your method in a way that you have both the parent compound and the metabolites. And as you can see here, the boxes that are kind of a light pink color, these are the prescription drugs. The ones that are kind of a grayish color, those represent the metabolites. And so you can see that some of these compounds, they are metabolites of other compounds, but they're also drugs in their own right. So some of the potential pitfalls of mass spectrometry are patient-specific ion suppression. So this is a decrease in sensitivity in an individual patient sample. So there's something in that specific patient sample that elutes off the column at the same time as a compound that's of interest to you, and it prevents it from being measured accurately. Another type of interference are isobaric interferences. So this is when two compounds have the same mass and you can't tell them apart unless you separate them chromatographically. For mass spec, additional sample prep might be needed. An example is if you're trying to measure total drug concentrations. So most drugs, or many drugs, are metabolized in the liver. When they go through our liver, a glucuronide group is attached to it to make the drug water soluble so that we can excrete it in our urine. So if you want to measure total drug concentration, you either have to look for the mass of the parent drug and the drug with the glucuronide attached to it, or you could do something called a hydrolysis reaction where you take that glucuronide group off and you're just looking for the parent compound or its metabolite. So there could be quite a bit of sample prep required. And then finally, the complexity of this technology can make it not only difficult to implement, but quite challenging to maintain if you don't have the expertise on site. All right, so now I'm shifting into the next part of this talk where we're talking about drug testing approaches. So in most clinical labs, urine drug testing has traditionally been a two-step process where you start with a screen and then anything that's positive will reflex to a confirmation. And so this testing scheme, it was designed a long time ago to detect drugs of abuse in workplace testing, and then it was adopted into the clinical setting. But as our need to manage treatment of chronic pain has evolved, so have our approaches for testing. So now there's more than one approach. So some of these aim to reduce the number of false positives, others aim to reduce the number of false negatives as well. And so it's pretty important then to define early on how you're going to use the test so that you can pick the approach that best meets the clinical need. So in the next slide, I'm just going to share with you some general drug testing approaches that are used. So this is not meant to be a prescription for you to do any of these, but I just want to share with you what's out there and to open your mind to the possibility of using different approaches depending on the clinical scenario. So the first approach that I'll describe is the one-step approach. And so this is where only an immunoassay screen is used, and then it's used to treat patients. So the results are used to make a clinical decision right then and there. An example of where this might be used is the emergency department. So if a patient presents with a suspected overdose, perhaps in a sickle cell crisis or having seizures, a physician might order a drug screen just to know what's on board so that they can make a decision right then and there to treat the patient. That being said, I do have to put out the disclaimer that these screening assays only do provide preliminary results. And so the instructions for use for them do say that confirmation is recommended. So clinical consideration and professional judgment should always be applied to any of these results, particularly when there's a preliminary result that's generated. The next approach is a two-step approach. So this is where an immunoassay screen is what you start out with, and then anything that's positive will automatically be reflexed to a confirmation if it's positive. So some clinical scenarios where this might be used would be pre-admission testing, in the inpatient setting, so for example, a labor and delivery ward or pre-transplant evaluation. You might also see this or this might be useful in the primary care setting for general screening. And then we have a third approach. This is described as an orthogonal or a hybrid approach. So in this approach, an immunoassay is ordered for some drug classes and a confirmation test is ordered directly for others. So instead of doing it two-step or stepwise, you're ordering them both at the same time and running them at the same time. So some examples where this type of approach might be helpful would be in the pain management or controlled substance monitoring setting, where a clinician will want to order directly a confirmation testing for the substances that they know that they've prescribed the patient, and then do a screen for all the other classes. So this slide shows the several different flavors of these orderable drug panels, so how you can operationalize those different approaches. And so these are panels that we offer at my institution. So we have just our basic urine drug screen, which is a 9-component screen, as shown here. Now, if a result comes up as presumptive positive, nothing else happens. The result goes out, and it's up to the physician to either call the lab or go into our electronic physician order entry and place an order for a confirmation test to be added on. The next level of test we have is a urine drug screen with reflex to confirmation if positive, and it's literally named that in our EMR. This test has the same exact 9-component panel, except for if anything comes up as positive, it automatically reflexes to a confirmation. So there's a rule built in our laboratory information system that says if any of these screens come up positive, automatically order a confirmation for that test. So we found this to be particularly helpful in settings where there may be medical legal consequences, or in the outpatient setting when a physician would order a test but not have the time to look at the results and call the lab to add on the confirmation testing before we'd already discarded the sample. And so typically, given the volume of our hospital, we really can't store samples for more than probably about 3 days. And so a lot of physicians were missing that window and then upset because we weren't able to add on the confirmation. So this was definitely helpful there. The next flavor of assay that we have is something that's much more specific to a particular clinical scenario. So this one is just, it's named Opiate Benzodiazepine Prescription Compliance Panel. So it's very obvious what it's intended to be used for, which is gauging prescription compliance to someone who's prescribed an opiate or benzodiazepine drug. So in this panel, we use the orthogonal approach or the hybrid approach, right, where we're ordering opiate, opioid, and benzodiazepine confirmation up front, and then for all the other drug classes, we are doing a screen. And if any of those urine drug screens are positive, that will also automatically reflex to a confirmation. So these are some examples of how we've chosen to operationalize these different approaches in our lab panels. And we don't have panels for every single scenario, every single clinical department. Many departments can benefit from just a single panel. For example, I would say most people tend to use our urine drug screen with reflex to confirmation. All right, so our pathology department has worked very closely with a number of other specialties to create our institutional drug testing guidelines. So none of these decisions were made unilaterally by the laboratory. So we collaborated with the Pain Management Institute, with the Primary Care Institute, with our legal and risk management departments when we were defining our controlled substance monitoring guidelines. And when we were trying to figure out what panels and approaches that needed to be used for inpatient drug testing, we had representation from several inpatient wards, our emergency department, IT to make sure things were flagging a certain way or being pulled from our EMRs, the legal, risk management, and social services departments. So I strongly recommend interdisciplinary collaboration when defining your drug testing guidelines for your institution. I will say that we often refer to clinical practice guidelines when possible. So if they were out there, we brought them to the table for discussion with the group. So some examples of helpful guidelines that I found to be helpful in my career. This one is the Monitoring Drug Therapy and Pain Management Patients. And so this was co-sponsored by the American Association of Clinical Chemistry and the American Academy of Pain Medicine. So this was particularly helpful in developing that opiate-opioid benzo panel. We also refer to consensus statements. So one example is the American Society of Addiction Medicine. And we also refer to just committee opinions that are published. So this was a joint publication by the American College of Obstetricians and Gynecologists, along with the American Society of Addiction Medicine on opioid use and abuse disorder in pregnancy and the testing recommendations. So I find all of these helpful. Whenever there were guidelines available, we would bring them to the table. If there weren't any, it was always a discussion with a much larger group outside of the laboratory. All right, so the next part of this talk relates to designing and optimizing drug test panels. So before you start deciding what individual components you should have for your test panels, you really should take a step back and start by defining how the test will be used. What's the goal? Is the goal to detect drug use, to detect drug abuse, or perhaps both? And what patient population do you intend on using this in? Is it meant for addiction medicine? Is it meant for the emergency department? What are the specific needs of that patient population? And that can help to help you decide what components you need to have in your panel and what makes most sense for that particular population. But I urge you to also consider these other essential features, like what analytical performance characteristics are required. Is a qualitative result sufficient, or does it need to be quantitative? What threshold should you use? Do you need higher or lower cutoffs? What specimen types do you want to accept? Serum, urine, etc. In some patient populations, such as those that have, let's say, kidney disorder, they may not be able to produce a urine sample as easily. So you'd also want to have a serum version of the same panel available. What turnaround time requirements are acceptable? So the clinical utility of a test has to do with, well, part of it is how quickly you can get the results back. So if someone in the emergency department sends out for a drug test and they don't get the results back for a week, that doesn't really help them in that moment, right? Because the patient will already be discharged before then. So just thinking about what turnaround time requirements make the most sense for how that test is being used. By considering all of these elements, this will help to ensure that you're creating drug testing panels and processes that are best suited for the clinical need in question. So another place that you can start, where I recommend starting your panels, is by referring to the federal government guidelines. So the federal government mandates that these specific classes of drugs are included in a federal workplace drug testing program. So these are amphetamines, cannabinoids, cocaine, opioids, and phencyclidine, which is PCP. So a long time ago, the Substance Abuse and Mental Health Services Administration, they deemed that these were the 5 drug categories that were most commonly abused. And so that's why they must be in all federal workplace drug testing programs. So most clinical labs will, at a minimum, start with these 5 drug classes. But many labs decide to expand their screening panels. And so some of the additional drugs you might decide to include may be barbiturates, benzodiazepines, fentanyl, methadone. There are a number of drug tests that are out there. How do you know which one to add to your panel? And so it can be challenging. So my advice to you are 3 additional tips are to 1, test for drugs that are commonly abused or prescribed. So the drug panels that you have available, they should be a reflection of the substances that are being used or abused within your community. I would avoid the urge to add trendy designer drugs. So tests for synthetic cannabinoids or bath salts. I'd avoid adding those to your conventional drug test panels unless you have the ability to frequently update them. So the compounds that are in designer drugs, they change and evolve very quickly in order to prevent being scheduled by the DEA. And so there's a very wide range of chemical structures that are out there, and that can make them hard to detect by just a single test. But if you have the ability to pivot quickly and to modify your method, then more power to you. I would definitely recommend that. But for most labs, by the time we complete a method development and validation to meet our regulatory components, there's already new versions of that drug on the market. Another tip would be to keep the panel as concise as possible. So avoid testing for non-relevant analytes. And so what do I mean by that? I mean analytes that don't add any value to your panel, because these can cause delays in turnaround time and extra costs, right? So you only get reimbursed one amount for your panel, no matter how many compounds are in it. And so you have to think, is this really adding anything to the clinical care for this patient? Are they gaining any additional information? Consider the return. And finally, I'd like to emphasize that there is no one right answer. So I'm giving you just some things to think about, but I can't tell you exactly what to put in your panel. But these are just some ideas to keep in mind. I'd like to encourage you all to look at some of the national drug use and abuse surveillance resources that are available to the public. I find these to be particularly helpful. So in the next few slides, I'll just give you examples of ones that I've come across that help me in my practice. So this first one is the Annual Surveillance Report of Drug-Related Risks and Outcomes, which is published by the CDC. Now, you could find this information on their website, and I've just highlighted 2 charts that I think are quite helpful, but just to illustrate the type of information that you'll find in these reports. So this first one, for example, shows the drug overdose death rate broken down by the drug or the drug class per year, right? And so here we see that the prescription opioid death rates have increased year over year, and we also see now that the dark horse coming up is the synthetic opioids other than methadone, which are now the ones that are responsible for the highest death rates. Another important chart that I saw that I found to be helpful is that it breaks down the rates of overdose by drug as well as the age of the patient or age of the individual. Another great resource is the National Drug Early Warning System, so NDUS, and so this is funded by the National Institute of Drug Abuse, so NIDA. So this system, there are 12 Sentinel hospital sites that are scattered across the nation, and they submit indicator data on a regular basis. So NDUS incorporates real-time surveillance to allow us to detect early signs of potential drug epidemics. And it provides a nice way to disseminate the data quickly and in a timely manner so that we can all act on it. So their reports are published annually, and then they also have a very nice summary if you don't have the time to read the full report as to what trends that they noticed. And so I've highlighted the 4 trends for 2020, and I found it interesting that fentanyl still remains to be the most lethal drug in many of these end-use sites, despite that they're geographically scattered. Another great resource is the SAMHSA website, so the Substance Abuse and Mental Health Services Administration. So they have a variety of reports and tools that are available on that website. One of them is the National Survey on Drug Use and Health. And so an example of some of the data that they have there is this shows heroin use in the past year among adults. And so you can see kind of like in a heat map which areas heroin use is most prevalent. They also have reports from DAWN. So this is the Drug Abuse and Warning Network. And so this shows trends in ED visits involving illicit drugs. And so it doesn't mean that taking this illicit drug was the reason why the person was admitted to the ED or presented to the ED. It just means that when they were at the ED and got a drug test, they screened positive for these tests. And so it's interesting to see what drugs are being mostly abused or most commonly abused. So you can also gather information on the local level from these federal websites or these national websites. So the NIDA website, they also allow you to drill down and get summaries by your state for some things. And so this is an example of opioid summaries that are provided at the state level. You get information like this. So the first image on the top left of the United States, you can see as a heat map the opioid-involved overdose death rates across the country. And as you can see, Ohio, which is where I'm located, we are in the heart of this opioid epidemic. We can then, so this we knew, but then it's helpful to be able to break this down and look and see, okay, well, these are the number of drug overdose deaths involving opioids in Ohio, broken down by prescription opioids, synthetic opioids, heroin that's purchased. So that's very helpful to see. We can also look at things like what are the prescription rates. So in Ohio, we see that Ohio providers ordered just slightly more prescriptions or wrote slightly more prescriptions than the average across the U.S. Yet it's disproportionate to the number of overdose deaths that we're seeing. We also can gather information about admission rates for substance abuse disorders into treatment facilities. So we can see what drugs are most commonly being abused and people are being admitted to these treatment facilities for. You may want to also look to see what type of local drug use and abuse surveillance resources are available. So we have something in Ohio called the Ohio Substance Abuse Monitoring Network. Now, this is a network that publishes these pamphlets or these reports about twice a year. And I find it to be particularly helpful because it not only breaks it down for just the state of Ohio, but by region. So I'm in the Cleveland region. And based on this report, what I could see is that fentanyl and marijuana and methamphetamine availability has increased, while ecstasy availability has decreased. And from what they're seeing, the consensus is that fentanyl is easier to obtain than heroin on the streets here. And so that's helpful information for us, and that's what guided us to realize we have to add fentanyl to our screen. So the national data coupled with the local data helped us to understand that this is really something that we have to incorporate into our drug panel. And so in the next month or so, we will have incorporated it into our panel in 22 sites across Northeast Ohio. I think it's great that they also provide more detailed information, like what the current availability is of prescription drugs as well as street drugs, what the changes in the availability, so whether it's decreased or increased since the last 6-month period, and of those drug categories, which particular drug is the most commonly available. So for example, for prescription drugs, apparently Percocet is the most commonly available in our area. I also found it particularly interesting and helpful that they also report the most commonly used cutting agents that were determined by the crime lab. So we see that for heroin, that it's most often cut with fentanyl and tramadol in our area. And we see that very regularly. And so this is also a reason why we're adding them to our drug screens. All right, so what additional tips can I give you for keeping your drug testing panels relevant? Well, I would regularly check these national and local surveillance data tools that I just mentioned. You may also want to consider crunching your own positivity rates over several years and consider removing drug screens that don't add any value. You may want to review reference lab positivity rate data as well. So I will tell you that we were playing around with the idea of removing PCP from our panel because we hadn't seen a positive PCP screen in a really long time. There were very, very few over a 3-year period. But after consulting with our clinical toxicologist and seeing information like this, which I'm showing here in the table or the image to the right, that there are actually small pockets in Ohio where PCP is still being abused. So it would not be smart for us to remove it from our panel. And so you can review reference lab positivity data to see what they're seeing in your area and see if that aligns with what you're seeing. And this might be particularly helpful if you're a smaller lab that doesn't have a very high drug testing volume. So the image on the right is from Quest Diagnostics, and it's showing the PCP positivity rates based on zip code. And it's very hard to see here, but it does show the pockets of cities in Ohio where PCP is still being used, which correlates to what our clinical toxicologist was also mentioning. I'd also continue seeking input from treatment professionals, so your colleagues. You can consider reaching out to the medical examiner's office, law enforcement in your area, and I also find instrument and assay vendors to be very helpful for consulting for things like this. They typically have their fingers on the pulse of what's going on, what's new, what's coming out there, so that they can proactively create commercially available tests to help us to fight these pandemics or epidemics. I will always recommend to attend professional conferences and seminars to stay up to date on the new drugs that are coming out or the new technologies that are available to help you detect them. And if you are willing to travel down the rabbit hole with me, this last one is quite interesting. It's checking web forums like bluelight.org, Opiophile, or Reddit threads, just to name a few, for open discussions about drug use. And so it's not a bunch of people talking about how great drugs are and trying to promote drug use. It's really intended to reduce the harm so that people will, if they are going to use drugs, that they do it more safely and can have their questions answered. So why would I ever recommend that you read these? Well, there's data and evidence that shows that social listening data can be really helpful for monitoring drug use and misuse. And so I suspect that there will be additional reports that we'll see coming out based on what people are finding by using social listening to these threads. So in summary, a critical first step to ensuring that your drug testing program meets your stated goals and is successful is to understand how the testing process works and what it can and cannot tell you. I hope that I've demonstrated to you that drug testing is not a one-size-fits-all process, that there are varying needs for different patient populations, and that you really need to consider the test characteristics that are needed. And I don't just mean analytical, I also mean the clinical and the operational. I encourage you to collaborate with other departments to develop your institutional testing guidelines and to create educational materials to help them know which test to order and in which scenarios. I'd also encourage you to collaborate with them to learn about their experiences on the front line, since they are the first to see new prescription drugs coming to the market, know how frequently they're prescribing them, or maybe they're seeing more illicit drug use that they can tell you that something is about to be big in our area. I also recommend regularly reviewing these national and local drug use, abuse, and overdose trends and evaluate them against your current panel to see what you can improve, what you might need to consider adding, removing. And I just want to emphasize that optimizing your drug testing panel is an iterative process. You can't just set it up and walk away and never go back to it. You must regularly go back and check to see what the climate is around you, what the environment is, what's coming your way, and then react accordingly. So with that, I'd like to thank you all for your time. I'd like to thank Thermo Fisher Scientific for sponsoring this webinar, and I am happy to take questions.
Thank you, Jamie, for your informative presentation. We will now go ahead and start the live Q&A portion of the webinar. If you have a question you'd like to ask, please do so now. Just click on the Ask a Question box located on the far left of your screen, and we'll answer as many questions as we have time for. Okay, let's go ahead and get started. Your first question is, which chromatography technique is best for drug testing?
That's a harder question to answer. Which one is best? I think it depends on what drug you're trying to test for. So some drugs are inherently more volatile than others. Others, you just will have a really hard time trying to derivatize them in order to get them to be labeled enough for GC to be the good method. So I think it depends on what panel you're talking about. I think GCMS has historically been the gold standard for confirmation testing, but I think more and more people are moving to LCMS because it tends to be more robust. So in the sense that you can test for more drugs without having to derivatize them, and you can work with a range of polarities. I hope that adequately answered the question.
Thank you. Okay, next question. Can immunoassays discern between delta 9 THC and delta 8 THC?
I don't believe so. I mean, but to be honest, I don't know the answer to that one. I know that in general, immunoassays, the antibodies are designed to recognize the 3D and chemical structures, and those sound like they are very close to each other. They will probably be able to detect both if it's able to detect it, but maybe at different concentrations. But those are very structurally similar.
Okay. All right, your next question. Can you detect LSD in a urine sample?
I'm sure you could detect LSD in a urine sample. I don't know that anyone is really using LSD much anymore, but yes.
Now, is the immunoassay used for drug screen a laboratory test or a POCT?
Well, it could be either. So it depends on how you choose to use it. In our system, I can tell you that we have some physician offices that have a point of care urine drug screen where they're either in a cassette-based form or a cup form. And then we also have one that's done in the laboratory, so on our larger chemistry analyzers. So the screen can be either, but the confirmation is always the same in our system. So we build it so that they will, all screens that are, well, I should say we built all of them, but screens that are positive always get reflexed to our LCMS confirmation in our laboratory. So there are several different screening modalities that are used.
Okay, I'm seeing this question a few times. The attendees want to know if the recording is going to be available for them to view later, and I do want to let you know that this event will be on demand. So you will be able to view the webinar again after it's finished today. Okay, let's go ahead and move on to our next question. What is the best test for alcohol?
Best test. In my time, I feel like it's evolved. I think now people are using ethyl glucuronide more, though I don't know how many labs actually have it on site. So I will say that in our laboratory, we just test for ethanol, but we do have several like addiction recovery services and several other specialties that we send out for ethyl glucuronide. So I believe that that is a better marker. We would like to eventually bring that in-house, but we have not done so yet. And I know that there are also several other markers that I see coming up that would be helpful, but I don't think that they have been adopted as widely in the general clinical lab setting.
Great, thank you. Now, what cut for AMP and benzo is recommended?
I'm sorry, I don't think I understand the question.
Yeah, this user says, what cut of for AMP and benzo is recommended? Or what cutoff? What cutoff for AMP and benzo is recommended?
Oh, okay, got it. So I think that depends on what you're using it for. I would say in general, for the workplace drug testing, the cutoffs are much higher, but in the clinical setting, it's quite a bit lower. So I could tell you that we use, for our amphetamine screen, we use a 500 nanogram per mil cutoff and a 200 nanogram per mil cutoff for benzodiazepines. So I think that for clinical testing, I would use the the lower cutoff so that you're able to detect more. If you're doing it for workplace testing, the higher cutoff is better because you don't want to pick up on people who are taking things that they are prescribed. You're looking for them taking drugs that they're abusing.
Okay, great. Thank you. Looks like we have time for a few more questions here. Next question is, can screen and confirmation both be done on LCMS?
That's a great question. So yes, they can actually both be done on LCMS. I think that few institutions have the ability to do that because LCMS is not so common that it's in every lab these days. But yes, they can both be done. There are several institutions that are doing that now and just bypassing the immunoassay screen altogether. And so I think that that's probably where the field is moving towards, but I think that until more labs can get their hands on LCMS, can have the expertise on site, I think that immunoassay will be around for a while. That's a very good question.
Great, thank you. Now, if a patient is using cough syrups or sleeping pills, will we get the positive results in drug testing?
You can. You get a false positive, or sometimes a true positive if it's an amphetamine containing medication on a urine drug screen, but that's where the confirmation testing comes into play to help you discern whether or not it's a false positive or a true positive.
Now, what about integrity checks?
Great question. So there are a number of things that you can do to check the integrity of a specimen. I will tell you that in-house we have chosen to do a creatinine check, and this is not for all tests. We've only included this in our opiate benzodiazepine prescription compliance panel, but we'll do a creatinine check to make sure that it's at a certain threshold to ensure appropriate concentration of the urine. If it is less than that threshold, we will automatically reflex to specific gravity testing. Now, I know that there's some labs that will also look for adulterants and things like that, but we are not currently doing that in-house. We used to send that out to a reference lab so that we could have it available to our clinicians should they feel that it's necessary to do that, but we don't do it in-house. So just creatinine and specific gravity is what we do in our clinical lab.
Great, thank you. Now, this question says, we have a client that takes Vyvanse and is positive for AMP and MAMP every urine test. How do I determine whether he is actually abusing meth, his drug of choice?
So there are higher level methods that can be used to detect street amphetamine from what would be prescribed. We don't run any of those in-house. So you're saying that his drug of choice is methamphetamine?
Correct.
Sorry, I just want to make sure I heard that correctly.
Yes, correct.
Okay, well, we can tell the difference between methamphetamine and amphetamine in these tests. We can also tell the difference between the D and L isomers of methamphetamine to determine whether or not it's coming from an illicit source versus a prescribed source. So I'm assuming then that this patient has also been positive for methamphetamine at some point. And you can differentiate methamphetamine from amphetamine in your confirmation test.
Okay, thank you. Now, heroin has a very small window of testing. What can I do to extend it?
I don't know how you can extend the window. I do understand where the question is coming from, that the very specific metabolite to heroin, 6-acetylmorphine, that's very labile, very volatile and doesn't exist very long, but you can detect the morphine and hydromorphone for quite a bit of time after use. We're also seeing that a lot of heroin is cut with tramadol and fentanyl, at least in our population, so we're able to see a very clear pattern of morphine, hydromorphone, fentanyl, and its metabolites. So while you won't be able to detect the 6 a.m. For very long, you can detect the other metabolites of heroin. further down the pathway.
Thanks so much, Jamie. We have time for one more question here. From a technical staffing issue, are you running LC-MS testing 24/7? And if so, at how many locations in your system?
Very good question. I would love to be able to run it 24/7, but unfortunately we don't have the staffing or expertise to do that. It's been challenging to even bring the LC-MS testing in-house because it's not something that's taught in med tech school, so we had to kind of train the staff ourselves to do this. So right now we offer it only on first shift. The intention is to expand as we bring on other types of testing to run it across at least 2 shifts. Right now we're running it only 5 days a week, and because of the equipment and the expertise that's needed, we have concentrated all of our testing to one site on campus. So we are kind of the mothership hospital. We are the largest hospital in our system, and we receive all of the work from the 12 community hospitals around us and all of the physician offices that use our testing services. I can tell you that one of the things that we have done in order to kind of streamline this process is we ensure that people use the same sample cup. We have special cups that we have them use so we can sample from directly onto our sample prep instrument. So we've done things to kind of streamline the process and still have a great turnaround time, despite that we're doing the testing for our whole system in just one location.
Well, thank you again, Jamie, for your time today and your important research. We would also like to thank LabRoots and our sponsor, Thermo Fisher Scientific, for underwriting today's educational webcast. And as a reminder, before we go, I'd like to thank the audience for joining us today and for their questions. Any questions we did not have time for today and those submitted during the on-demand period will be addressed by our speaker via the contact information you provided at the time of registration. This webcast can be viewed on demand, and LabRoots will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's live event. Until next time, goodbye.